Go ahead, ma'am.
Good afternoon, everyone. I'm Dr. Parinaaz Parhar. I'm the clinical head and consultant at Oasis Fertility, Secunderabad. Today, we are going to be talking about the fertility options for treatment at advanced maternal age. What do we mean by advanced maternal age? Now, advanced maternal age is where the female partner is more than 35 years old. So, today's talk is mainly aimed at those couples where the wife is more than 35 years, whether it's where you're trying for your first pregnancy or if it is for your second pregnancy and you find yourself at the other end of 35. Well, today we're going to be talking about what are the treatment options available for you to maximize your fertility. Now, why are we talking about this particular group of patients? Because their requirements, their needs, and their risks are very different from what we see in a regular patient who is aged less than 35. And how is it so? So, this is a beautiful graph which tells us about the impact of the maternal age on fertility. Now, as you can see, as the maternal age is increasing, there is a sharp decline in the fertility. And this decline is more obvious after the age of 35 to 39. Similarly, even if you conceive at this age, as you age more than 35 to 39, unfortunately, your risk of abortion also increases. Now, why is it so that we see such an adverse impact of age, advancing age on the fertility of a woman? To understand this, it's very important to understand that as ladies, we are born with a fixed number of eggs. We have a finite number of eggs, and all the eggs which we are going to use, which we are going to release during our lifetime, are formed while we are still in our mother's womb. So, whatever eggs we are going to use throughout our life are going to be from that finite pool of eggs. When we talk about males, they produce sperms every day. So, age is not that harsh to the male partner. Now, if I am 35, my egg's age is also going to be 35. If I'm 40, my egg's age is going to be 40. And obviously, as we are aging, the egg quality is going to deteriorate. And that simply explains why you have more abortions as a lady's age increases. Also, the risks of having a child with some chromosomal syndrome, with some abnormality, like Downs, also increases as your age increases. So, there's a sharp decline in the quality, there's a sharp decline in the quantity of the eggs. And that's why your fertility decreases as you advance beyond 35. Now, this simple fact is what really determines all our decision making as far as a lady of more than 35 years is concerned. When a patient who is less than 35 years approaches us for treatment, we usually ask them that how long have you been trying for a baby? If you're aged less than 35, you are asked to undergo an infertility workup, not unless you have tried at least for 1 year. Now, because age has such an impact on the female's fertility, once you cross 35 years of age, this time period is reduced to less than 6 months, to 6 months. So, if you are someone who has been trying for 6 months with regular intercourse without much success, you need to consult a fertility expert if you're aged more than 35 years. Now, what is the evaluation that they're going to be subjecting you to? There are three main things that we would be testing you for. They will be seeing what is your ovarian reserve, or to put it in layman's term, how many eggs do you still have remaining? The other thing that they're going to be testing for is whether your tubes are patent, whether they are open or not. And the third basic thing that would be tested is your husband's semen parameters. Now, when I talk about the ovarian reserve, that is the single most important thing which is going to decide what treatment that you're going to be subjected to. The ovarian reserve of a lady is usually tested with the help of her AMH, the serum follicle stimulating hormone, and the antral follicle count. What do all these terminologies mean? When I talk about the anti-Mullerian hormone or the AMH values, this is basically a blood test. This test can be conducted on any day of the cycle. You don't need to be fasting for it, and it will give me a rough idea as to how many eggs do you have remaining. Similarly, the antral follicle count test, or the AFC, is an ultrasound test which helps me know about how many small follicles do you have on day 2 or 3 of your cycle in both your ovaries combined. Normally, in someone who has a good ovarian reserve or who has a good number of eggs, I would be expecting about anywhere more than 5 to 7 eggs in each ovary. So, a combined antral follicle count of more than 10 to 14 is considered normal. So, and when we talk about the the FSH values are usually the blood test which is done on the second day of your cycle. So, together the follicle stimulating hormone, the antral Mullerian hormone values in the blood, and the antral follicle count, which is a test done using ultrasound, these three parameters will help me know what is your ovarian reserve. So, it's not just about the age affecting the quality of the eggs and the quantity of the eggs. Age also makes pregnancy much more risky. As you can see from this particular graph, with age, not only is your fertility reducing, your risk at pregnancy is also increasing. Okay, it becomes a high risk pregnancy as your age advances beyond 35 and exponentially so thereafter. So, because your fertility is declining and the risk to pregnancy with advancing age keeps on increasing, these are the two main factors which really govern the decision making at this age. That's the reason why we really, as fertility experts, want to help you get pregnant as soon as possible post this age, because the success rate keeps on declining with every passing day and the risk to pregnancy keeps on increasing. So, how do we try and optimize your chance of getting pregnant at age more than 35 to 37? Now, as we can see from this particular graph, this will give you an idea how our decision making varies at different ages. When a patient is less than 33 years, if they come to us with complaints of infertility where they have tried for more than 1 year without much success, we would be a bit more conservative in the approach and we would say, okay, fine, let's just see if you are subfertile. Let's just try, we'll tell them what is the right way, what are the days, what is the fertile window, when they really need to try and have intercourse and have expectant management for a couple of months. If that doesn't work, we will really move on to trying with either tablets or with injections to try and get as many eggs ready and monitor when the lady is ovulating and ask the couple to have intercourse around that time. If that doesn't work, then the patient would be asked to keep have about 3 to 6 cycles of IUI. And if that doesn't work, then they go on to an IVF or ICSI. This is usually done for patients who are younger. However, you can see a sharp contrast into the treatment approach which is adopted for someone of elderly age. Here, the duration that we wait for is usually not more than 6 months. Once you've tried for about 6 months, we start evaluating you. It's accelerated, the whole process is accelerated where you just bypass the expectant management and we move forward towards an IUI. The IUI is tried for about 3 cycles, and if that's not successful, the patient is actually encouraged to consider going for an IVF. Cut to a time when the lady's age is more than 37. Here, the treatment approach which would be adopted would be that, okay, try for 1 to 2 cycles of IUI, and if that is not really working out, then go on to an IVF or ICSI. Now, you would ask me, why are we really pushing forward like this? What is the need? What is the hurry? A lot of patients would be like, why is this doctor so obsessed with time? Well, that's because we have your best interest at heart. Like I told you earlier, it's the deteriorating success rates and the increasing risks at pregnancy, which make us really concerned about not delaying your fertility further and trying to get you pregnant as soon as possible. Why have we reduced the number of IUIs to less than 6 to just about 2 to 3 before moving on to an IVF in this particular age group? The slide will tell you. Now, for those viewers who don't know what an IUI is, IUI basically involves the patient being stimulated, usually using tablets or drugs and injections, and we try to get about 2 to 3 follicles ready. The patient is monitored with the help of ultrasound scans, and once the follicles are ready, that is, once they're about 18 to 20 millimeters in size, we give an injection for their release. Once we have confirmed the release of the egg from the ovary, then we ask the husband to give his semen sample. This semen sample is processed in the laboratory in order to get the best quality sperms, and a high concentrate of good quality sperms is then inseminated into the female partner's uterus. We try to do it as close to the released egg as possible. Now, IUI is possible as a treatment option for you if you are ovulating, either naturally or with the help of drugs, if your fallopian tubes are open, and if the husband's semen parameters are meeting a certain criteria. If the husband semen parameters are too deranged, if the motility is very poor, if the count is very low, well, in that case, IUI is not the option for you. Now, like all other treatment options available, the IUI success rate also sharply declines post age 35 years. Normally, for a young patient, the success rate of an IUI would be somewhere between about 15 to 25%. On an average, for someone who's less than 35 years, we usually tend to quote a figure of about 15 to 20% for the success rate of an IUI. But as you can see, as the lady's age, as the female partner's age increases, the success rate of IUI sharply declines to about 5 to 10% and not more. So why? Why would I really subject a patient to something with such low success rate when I know that the egg quality and that when I know that we're really fighting against time? So that's the main reasoning why for younger patients, I might do for up to about 3 to 6 cycles of IUI. But if your age is more than 35, I would restrict myself to not more than 2. Now, this was about IUI. Now, suppose if you're someone who's got where you have very low number of eggs, where your ovarian reserve is very less, or if you have blocked tubes, or husband semen parameters are grossly subnormal. The count is very low, or the motility is very poor, or for that matter, we have to use testicular sperms. Or if we're someone who has already tried 2 cycles of IUI without much success, well, in those cases, you would be considered for an IVF cycle. Now, what is an IVF cycle? IVF cycle usually involves stimulating the ovaries. I spoke about the antral follicle count in the beginning. So whatever is the number of small follicles that I'm seeing at the start of the cycle, I would try and stimulate all those follicles with the help of injections. On an average, a patient would need about 10 to 12 days of injections. When these follicles are ready, when they're about 18 to 20 mm in size, then under anesthesia, using a transvaginal approach down from below with the help of a needle, these mature eggs will be retrieved from the follicles, which are basically cysts inside the ovaries. These eggs will be individually combined with the male partner's sperm in the laboratory. Then these embryos which are formed are then cultured in the laboratory for up to about 3 to 5 days. These embryos are then transferred into the female partner's uterus once the lining is deemed suitable for a transfer. Now, this can be done either in the same month or the next month based on the doctor and patient's joint discussion. So this is what the embryos are going to look like when they are cultured in the laboratory. You have a day 1 embryo, then you have a day 2 embryo, you have a day 3 embryo, and day 3, which is the cleavage stage of the, I'm sorry, I don't think the slide is very clear, but I'll give you a rough idea about what it tells. On day 3, which is the cleavage stage of the embryos are supposed to have about 6 to 8, at least 6 to 8 cells of equal shape and size. On day 5, it is supposed to be a blastocyst. So what happens in a blastocyst is that there is a fluid-filled cavity. You have an inner cell mass, and you have an outer trophoectoderm. And this is an image of a hatching blastocyst. So the strategy when we are trying to do an IVF for someone of advanced stage is to try and get as many eggs as possible. And I'll tell you why. So we try to get as many eggs as possible. And this is usually achieved with the help of daily injections to the patients for about 10 to 12 days. Now, if you're someone who has less eggs, I might not get the required number of eggs in the first cycle itself. And in that case, I might need more than 1 cycle of stimulation for you. So if you're someone who needs to go for an IVF for your fertility, what are the options available for you? Now, there are various options based on your needs. If you're someone who's young, who's unmarried, who doesn't have a partner, but who is acutely aware of a declining fertility, well, in that case, social freezing or freezing your oocytes is an excellent option for you, and I'll be talking a bit more about that. If you're someone who's married and is suffering from infertility and you have been told that IVF is the only option, then controlled ovarian stimulation is the best option for you. In this stage, in this particular option 2, deciding to go for a blastocyst stage transfer where the embryos have been genetically tested to rule out any abnormality would be the best option, and I will be covering that in the later slides. And in case you're someone who has tried these options without much success, or you don't have many eggs left and you are not ready to face the success rates with your own eggs, well, in that case, donor oocyte option could be an excellent option for you. So I'll be covering these various treatment options one by one. Now, when we talk about social freezing or oocyte cryopreservation, look at it as a sort of reproductive insurance, which is against your age-related infertility. How is it an insurance? Because it is reducing your incidence of need for oocyte donation in the future. If you freeze your eggs today and say you find the right partner and you are ready to start a family, say at about, suppose you're about 35 years old today, and you are financially independent and ready to start a family at say at about age 40. If you have frozen your eggs at age 35, you can use those eggs. You can use those good quality eggs frozen at that age and use them to get pregnant at age 40. How will this help you? This will help you because it will drastically reduce your age-related risk of having a genetically abnormal child. So it's an excellent option for those of us who believe we are not yet ready for starting a family. However, what is the right age for exercising this option? Ideally, you should be looking at this option when you're aged less than 37 years in order to maximize the benefit. However, I will be talking about why do we say that? Because as your age advances, you need many more eggs in order to overcome the age-related risk of aneuploidy of the eggs. Now, I spoke about something called as, that was about social freezing in brief. I also spoke about using the option of PGTA or the embryo biopsy in order to select the best embryo for transfer when you undergo an IVF. Now, what is this PGTA? PGTA, the full form is pre-implantation genetic testing for aneuploidy. Now, normally when you get pregnant, how do you come to know whether you're having a normal, healthy child or not? During pregnancy, you are regularly subjected to various blood tests and scans once you are 12 weeks pregnant, once you're 20 weeks pregnant, in order to find out whether the baby is growing fine and whether all the organs are looking structurally normal or not. Now, pre-implantation genetic testing means that we are testing for these abnormalities before transferring the embryo to you. And how do we do that? This is a blastocyst stage embryo. We biopsy about 5 to 10 cells from this embryo and we send them for testing for various abnormalities. Now, why are we talking about this particular test? Why do we need to do this extra set of intervention for patients who are more than 35 years? It's not compulsory, but it is advisable. And why is that so? Now, this is another beautiful diagram which will help you understand how PGTA helps. How do we reach the PGTA stage? In order to enable PGTA, you have to first undergo a controlled ovarian stimulation where your eggs are retrieved. They are combined with the sperms in the laboratory by ICSI. The embryos are cultured to reach the blastocyst stage. Now they are subjected to the biopsy. The cells which have been retrieved are subjected to an NGS platform in order to determine whether the representative cells are genetically normal or not. The whole basis of PGTA is that the 5 to 10 cells which have been removed, they are expected to be representative of the genetic makeup of the entire embryo. Now, this will help us determine whether the embryo from which the cells were taken out, whether it is genetically normal, which is called as a euploid embryo, or whether it is genetically abnormal or an aneuploid embryo. How does it differ from a non-tested embryo? As you can see in this comparison, if I'm putting an untested embryo versus if I'm putting a tested embryo, doing a PGTA drastically reduces your risk of having a baby with some sort of chromosomal abnormality. It drastically reduces your risk of having an implantation failure, and it really brings down the miscarriage rate. So that's how PGTA helps. And because it's giving you so much of confidence in every embryo that you're transferring, it reduces the risk of multiple pregnancy. How? Because I'll explain that in the subsequent slides. Now, but to put it in simple terms, how is PGTA really helping you? It helps you reduce your risk of miscarriage. It helps you reduce the time to pregnancy because it helps me select that out of all the embryos which have been formed for you, what is genetically normal. And it helps to reduce the risk of multiple pregnancy because it's giving me the confidence of putting only one embryo at a time rather than putting 2 embryos which are untested. So, this is a study which was published in a reputed journal in 2023, and you can get an idea about why PGTA is important from the data which I'm going to share. For someone who is aged less than 35, the chance of having a genetically abnormal embryo is about 20%. Say for this patient, I get about 5 embryos, maybe one odd embryo will be genetically abnormal, the remaining four will be good, which gives us a fair chance of success even if we don't test these embryos. However, as you move to age 35 to 37, the risk of having a genetically abnormal embryo would be as high as 30%. And it keeps on increasing, where when you reach age 43, it's almost 85% risk of having a genetically abnormal embryo. That high the risk is. Obviously, PGTA is more indicated as your age is advancing to help you make the right choice. Now, suppose if you say that, no, I don't want to undergo PGTA, I don't want that extra intervention. Well, in that case, if your embryos are untested, to help you achieve almost a 95% chance of implantation and a healthy pregnancy, at age 35 to 37, you need at least 5 untested embryos, and this number increases to as high as 27 at age more than 43. On the other hand, if I do a PGTA, across all ages, roughly my chance of success per cycle, my implantation rate per cycle on an average would be approximately 50%, which is fairly good. So that's the reason I have more confidence in transferring only one embryo for this patient. As we all know, twin pregnancy is high risk. As it is, pregnancy is high risk more than 35 years. So we want to get a lady who is more than 40 pregnant with a single pregnancy, with a singleton pregnancy. PGTA not only gives me the confidence of having a genetically normal child, of having a genetically normal embryo transplant, because I'm more confident of the results, I can take the chance of putting only one embryo at a time. If I don't test the embryos because of the high risk of having an aneuploidy, I would be tempted to transfer more than one embryo. There are some centers which even do about 3 embryos transfers, though it's not really legal anymore. But yes, on an average, for someone who's more than 37, a lot of us transfer at least 2 untested embryos because of the high risk of having an abnormality. Now, this was about PGTA and IVF. What about those patients who don't have many eggs, or those who have had repeated IVF failures, or those where the egg quality is proven to be very poor? Well, in those cases, oocyte donation is a good option. What do you do here? So these patients usually find it difficult to conceive because the egg quality is very poor. So how do you overcome that? You use the egg of someone who is younger, who's previously had a child, who gives you permission for that. That lady is stimulated. She's an anonymous donor who matches your blood group, and she is stimulated. Her oocytes are retrieved instead of yours. These oocytes are combined with your husband's sperm in the laboratory, and the embryos which are formed are then transferred in the recipient's uterus. So for all practical purposes, you are the mother of the child, but your genetic makeup is different. The child has 50% of the genes from the donor oocyte and 50% from the male partner. So oocyte donation is an excellent option for those ladies where egg quality is the reason behind the infertility. According to the latest ART bill in India, this can be exercised. This option is available to ladies right up to the age of 50 years. And it is a good option. What is the success rate? It's as good as someone who's less than 35 because the eggs which are being used are from a lady who are less than 35. So there's a very good chance of success with oocyte donation if you have a good uterus. So to summarize, what are the treatment options if the female paid partner's age are more than 35 years? What are the take-home messages from today's Facebook Live? Firstly, you need to understand that there's going to be a sharp decline in both the quality and the quantity of the oocytes with increasing age. Next thing, if you're more than 35 years, don't wait for an entire year of trying in order to get evaluated. You need to be a bit more accelerated in your approach, and probably if you've been trying for more than 6 months without success, it's time to meet your fertility expert. If you're found to be suitable for an IUI cycle, it would be wise to attempt a maximum of 2 cycles and not more because of the declining success rate with advancing age. With IVF, the success rate can be optimized by pulling out the embryos with strategies like double stimulation. Social freezing or oocyte cryopreservation is an excellent option where the female's age is less than 37 years preferably. PGTA helps to reduce the time to pregnancy and the miscarriage rate, and also gives us confidence to go ahead for a single embryo transfer even if the mother's age is more. And Oocyte donation can be availed by women up to the age of 50 years as per the current Indian ART bill if required. Thank you very much. That was all for today's talk. If you have any questions, you can post them up in the chat box and I'll have a look at them. Well, you can post your questions and we can get back to you. And thank you.